Thank you, and thank you again for coming this morning. So we're going to go from the sublime because that study by Dr. Greenspoon was just seminal. It really is a very important study. But there's a theme there that's probably going to be carried out throughout the rest of the day, and that is infection, inflammation, disease. So they wanted me to talk about mortality in people that are HIV positive and screening recommendations, which is a little bit more difficult than it seems because there are no clear screening recommendations for people that are HIV positive. So I'm going to bring together at the end classic recommendations and some of Dr. Rodriguez's recommendations. All right, take those as you will. So this is my disclosure. So I always like to get a bird's eye view of where we've been, what we've been through, and where we are, so that we can see where we need to go. So this to me is a very important, we doctors like to call this, and researchers, cartoon, right? It's a schematic. And it basically shows the number of deaths per year since the pandemic started. So I think the first cases, reported by our friend Michael Gottlieb were probably in 1981, even though probably without a doubt, the pandemic was still brewing earlier than that. Sometimes we think maybe even, who knows, a decade or two before that, but the manifestations started showing in the early 80s. And just coincidentally, I don't know if we can have a marker. Yeah, we go. This is actually where I saw my first patient with HIV when I was an intern in 1983. And at that point, many of us lived with the fear of something that was going on, but not really knowing exactly what was going on. And as you can see, I don't know where the marker is, there was a huge escalation in the number of deaths that peaked probably in 1984 or so. And then something dramatic happened here in 1995, and those were the protease inhibitors. And the protease inhibitors and their use in the general population dramatically, decreased the number of deaths from people that were living with HIV. I like to bring this up because in this decade that preceded that, so much work was happening. Everything from AZT trials to so many things. So this is where the scientific sausage was being made, right? And it wasn't pretty, right? So I always sometimes laugh, but get a little bit annoyed, like with the COVID epidemic. The general public was seeing in real time what was going on, right? And they're like, oh, scientists and doctors don't know what they're doing. Yeah, we do know what we're doing. We just don't know what the virus is doing. So therefore, we learn and we change and we tack. So the successful use of medication at this time drastically dropped the number of deaths in people that are HIV positive. But look what's happening. Even though we've dropped it, there are still people, approximately 10,000 a year, as far as we can tell, dying, and that's in the United States, of HIV. Worldwide, it's a much bigger epidemic. So what's been the progress? Especially after 1996, the availability of protease inhibitors. One pill, one a day therapy revolutionized the treatment also. For those of you that have been doing this for a long time, you remember Crixivan, where people had to take approximately 16 pills a day, if not more, on an empty stomach, not within 4 hours of the last pill. Adherence was horrible. So probably when a triplet came out, right, that was revolutionary. I also think that's one of the coolest names of a drug, a triple long-acting therapy, a tripla. Pre-exposure prophylaxis, all right? PrEP has revolutionized the number of people getting HIV. PrEP is 99%, perhaps 100% effective with some of the data that was given today with injectables in preventing. Integrase inhibitors have revolutionized the treatment of HIV. Why? Because they're safe, they're effective, the barrier to resistance is super high, and now we have even longer treatments, every 2-month injections. So what does the future hold and what can we do? In order to get this information for today, let me tell you, it wasn't easy. Because if you're trying to see what people die from, you basically have to do an analysis of multiple cohorts, multiple different studies. And for those of you, who have ever signed a death certificate, know that it's kind of a little not arbitrary what you put as the cause of death. So if you're trying to analyze cases and you're trying to see what people died of, one doctor may have put something, heart disease, the other doctor may have put different things. So to try to get that data into something cohesive is a little bit, a little bit difficult. So I primarily looked at two studies that were done over the past couple of decades. One in the Journal of Clinical Infectious Diseases that looked at approximately 40,000 patients over 20 years. So 13 different cohorts. And then I looked at another study, very comprehensive in the Lancet, that looked at approximately 189,000 patients, a lot, over 20 years, 17 different cohorts, and tried to make this as cohesive as possible. So one thing to start off with, this, and I wanted to reiterate this, treatment helps. And as Dr. Greenspoon mentioned, as other doctors are going to talk about today, HIV is a chronic inflammatory disease. All right, so what does that mean? That means that the sooner you can get someone on treatment, not only are they going to survive in the short run, they're probably going to have less complications in the long run. So this little graph here basically shows that people dying of AIDS, well, the longer you've been, and this is a horrible color representation, but the longer you've been on HIV medications, the less likely you are to die of HIV, right? And almost in everything, the more you've been treated, the different potential causes of death decrease. Now, there are some where it doesn't decrease at all. Liver-related diseases, cardiovascular diseases. And why is that? Perhaps it's because even though you treat it, you've already started a chronic inflammatory response. So, the good news is that depending on when and how long you've been on heart, the death in people have decreased. So therefore, all right, the year people started on heart, there was an 8.7% death rate. With time, it has decreased to 1.9. The whole point of that is that antiretroviral therapy is definitely helping mortality. But the more important thing for us today is what are people who are HIV positive dying from, and what can we do about it? So the colors again are not the most vivid, but I thought this was a very interesting and important graph in that back in the late 1990s to 2000, the majority of people, all right, this is green, were dying from AIDS and AIDS-related illnesses. Right here, there were people, and we don't know what people died from, all right? And that has stayed the same, the unknown. But what has increased, notice here, cardiovascular diseases, all right? And also what has increased or has stayed the same, liver diseases, all right, the light purple. And this is something that I think is super important I want to touch on because we tend to not really pay attention to it. Just as much as cardiovascular diseases, and sometimes suicide, drug overdoses, and violent diseases that people die from is just as important. So I was talking to Christian earlier, and he said, yeah, the bottom line is we just have to treat our patients as people that are getting older. And I looked at him and said, damn it, you just gave my talk in 30 seconds, but that really is what this is about. So these are little whisker things, and sometimes I think we really need to explain what these graphs are so that people that may not do this on a daily basis know what these are. These are relative risk whiskers, what I call. Anything where the relative risk goes above 1 means that the relative risk is increased, is still present, is more than it was. Anything below 1 means that things have improved. So if you want to compare a study, what was before, what is now, and you do the relative risks, notice that the relative causes of death in people that are HIV positive, obviously dying of AIDS has decreased. Cardiovascular disease has decreased, all right? And you think, well, you just said it increased. What I said is that the percentage is still approximately the same. The absolute number has decreased, but the percentage and causes of death, right, has increased. But what basically the relative risk has increased, CNS causes, central nervous system causes, and you may say, well, we're not seeing any more cryptococcal meningitis. What does that mean? And this is where it was difficult to like sort of mine this data, because dementia is a CNS cause. All right, cognitive impairment leading to other problems. Some people have put that as a cause of death. And that is what we're seeing increase with time in people that are HIV positive. Respiratory diseases has increased. No longer pneumocystis pneumonia, that's what was killing people with HIV and AIDS. Other respiratory diseases, COPD, lung cancer. Seems like the same thing that kill people that are HIV negative. All right, that's going to be the theme here. So, there was a time when the cause of death was from AIDS in people that were HIV positive up to 49%. All right, I'm just going to talk now about that. If a lot of you don't know, a lot of the staff that I work with are here, and they're younger people that haven't really been around, like those of us that are able to get Medicare if we wanted it. But people used to die of very rare infections that were only present because the immune system was low. You don't hardly see these anymore. Pneumocystis pneumonia, what's that? Cytomegalovirus, Kaposi sarcoma, all right? Cryptococcal meningitis, and something called PML, progressive multifocal leukoencephalopathy, which I used to call cottage cheese of the brain. All of these were rare infections that luckily we don't see anymore. However, and here's the caveat, if you have a patient who may be virologically suppressed, their virus, all right, but their T cells are still below a certain part, below 200, chances are that they're going to do okay, but you still have to have a high index of suspicion that these people, if they get ill, may still be getting those horrible old-fashioned infections. All right, so remember that graph I showed you about that showed what happened in the 2020s? This is what we're going to talk about now. What are people with HIV dying of nowadays? The number one thing that people are dying of is what's called non-AIDS malignancies. What is a non-AIDS malignancy? Hodgkin's lymphoma, lung cancer. And there's going to be a lot of overlap. All right, so you have a 65-year-old man that comes in, he's HIV positive, his virus is suppressed, he's starting to lose weight. What do you think of? The first thing you should think of is that he has some sort of cancer. All right, colon cancer, lung cancer. Basically, and this is the theme, the same thing as anybody else who is that age, and perhaps even a little more high index of suspicion, all right, because of a chronic inflammatory state. A non-AIDS infection, what does that mean? Sepsis, pyelonephritis. The most common one, acquired community pneumonia. All right, for people that are HIV positive, they're dying of non-AIDS infections. The theme, your HIV patients need to be thought of more than just HIV patients. They need to be thought of as complete people of a certain age. So I'm not going to show you all these fancy things, you know, because I didn't train at Harvard, but I went to University of Miami. We got a tan and we got an education at the same time. But this should be a little bit more real world treatments. So the most frequent sites of non-AIDS malignancies, 37% were respiratory or intrathoracic organs. Again, lung cancer, all right? Thymomas, Hodgkin's disease. You're going to find something here. What is probably the main association with these diseases and HIV? Cigarette smoking. All right, so something that we may just poo-poo, it is probably more important in our patients to try to take that risk factor out of their life as possible. So again, if all we're doing with our HIV patients every 3 to 6 months is coming in saying your T cells are good, your viral load is great, it's undetectable, have a good day, we'll see you again, we're doing a disservice to our patients. I will venture to say that nowadays the HIV control is the easy part, all right, of treating our patient population. Digestive organs, something that is near and dear to my heart, all right? What does that mean? Hepatocellular carcinoma, stomach cancer, colon cancer. That is what people that are HIV positive are dying of nowadays. Oral cavity cancer, lip cancer. Again, smoking, head and neck cancer. All of those things are important. And skin. This is going to be a little bit ironic. I consider anal cancer skin cancer, right? Because the first 2 to 3 inches of the anus is basically squamous cell, which is the same thing as the skin. All right, so we need to consider that. Some may disagree, but that is actually in some of the death certificates and things, that is what they title the skin cancer. All right, so what is the main thing that people nowadays that are HIV positive are dying from? Non-HIV related malignancies. So what's important? Checking their lungs if they're a smoker, colonoscopies, et cetera, et cetera. What is the second biggest cause of death in people that are HIV positive and controlled? Cardiovascular disease. So Dr. Greenspoon just gave a brilliant seminal discussion on that. So for those of you that know me, I very often get on my soapbox, all right? And one of the biggest obstacles that I find nowadays in treating patients, all right, is trying to get patients not to treat themselves. All right, so what does that mean? Here's my theory. You don't want to be on a statin, right? Because your neighbor told you that they had some joint diseases. You're going to find everything on the internet that supports your belief. All right? Why shouldn't you do that? Because you're not objective about yourself. All right, we just saw unequivocally that statins in people that are HIV positive, and probably in everybody, saves lives unequivocally. Okay, so myocardial infarctions, which is basically a heart attack, 3.2% more or less of people that are HIV positive die from heart attacks. Strokes, 1.4%, another heart disease. What do you mean other heart disease? Pericarditis, aneurysms, all of these things that we should be screening for. So this to me, and I want to go back to this. I don't know if we can. Well, we can't. Heart disease, 7.9% of people that are HIV positive die from heart disease. 7.8%, almost equivalent, all right, to people that die of heart disease, HIV positive, people that are on medication, die from different causes, violent causes, suicide, substance abuse, other violent deaths, in other words, bad relationships, being robbed, all right, being killed because you're transgender and you're walking around the street. So this is not just a touchy-feely part. This is a very realistic part of what we need to be doing with our patients, is considering all of the parameters. And I'm glad that today we're talking about interdisciplinary causes of death. All right, our patients are no longer 23-year-old necessarily, young people that have no other issues. And one of the things that I urge you to not fall part of is the normalization of drug use that I think is pretty common in the gay population. All right, for those of you that have had the come to Jesus moment, right, and have chosen sobriety, All right, you know the difference between where you are now and where you are then. So sometimes we just normalize and take it for granted. Oh my God, so what? You know, I spoke to a friend of mine in Fort Lauderdale who got some dermabrasion because you have to look pretty if you live in Fort Lauderdale, right? But his face was just all purulent and pustular, and and of course I'm not his doctor, but he wanted some advice. We gave some advice, and I go, "So what are you doing?" He goes, "Well, the worst part is trying to sleep at night, so I'm taking some of my Xanax and I'm taking some K and some GHB to knock me out." But it's part of us, we just say, "Oh, that's not a big deal." Yeah, that's not normal, folks. That's not normal. And it does lead to other problems. So we need to take it seriously. All right. Next cause of death is liver-related illnesses. So this was a bit confusing in looking at it because some of the liver-related illnesses, for example, cancer of the liver, was already found in malignancies. So as a person who originally trained in gastroenterology, let me try to shed some light on this. Hepatitis obviously is an inflammation of the liver. What this hepatitis-related illnesses were people that had acute hepatitis or chronic hepatitis that died just from liver failure without having cancer. So these are the people that died from cirrhosis, that died from bleeds from cirrhosis as opposed to liver cancer. All right. And this is the other liver-related illnesses. But in here, they actually also put pancreatitis. All right. So pancreatitis, if you have a hemorrhagic pancreatitis, it also relates actually to the alcohol part, which is what I just spoke about. So these are all interrelated. And then we go to some of the least common causes of death. Respiratory disease, which is usually COPD, emphysema, bronchitis, renal failure. Now, I want you to keep something in mind. What was spoken of earlier today was the cascade of inflammation that happens when you have a virus like HIV. And then, let me get on my soapbox. Geez, there are other viruses that are nowadays floating around, all right? Like COVID. Did people think, oh, I got over COVID, not a big deal? Wrong. That is causing a chronic inflammatory disease. So that needs to be kept in mind. So respiratory disease, renal failure, we need to follow our patients very closely, not just because some of the medications can be toxic to the glomeruli and the kidneys, but also because the HIV virus itself can do that. So taking this all into consideration, what I want to bring out and sort of recommend is that the first thing we need to do, because the first slide I showed that if you're HIV positive, being on medication, the longer on medication, the healthier you're going to be. The first thing we need to do is lower the patient's viral load, the amount of virus in their body. Let me fix that. That's incorrect. This is the amount of virus in their serum. All right, what we're not measuring, what we can't measure is the amount of virus in their body. Not only latent cells that have virus, but other parts of the body where the virus is still circulating. But the least and the most we can do at this time is to decrease the viral load, because lowering viral load correlates to greater survival. So I already mentioned this. If someone technically has AIDS, and there are many definitions of AIDS, but one of them is if your T cells are below 200, all right, then you have to be suspicious if they get sick of them having an opportunistic infection, even if their viral load is undetectable. Their immune system is still too low. So also remember that the longer someone has HIV, the greater the risk of long-term inflammatory diseases, kidney disease, heart disease, brain disease, cognitive changes. And I want you to also expand the way we think about cognitive changes, because cognitive changes is not just about not being able to remember where you live or who your spouse is. It's about being able to feed yourself, being able to ask for help, being able to survive, and that leads to death. Failure to thrive leads to death. So prevention recommendation that are non-AIDS related. And these are basically, all of you that are internists, when you look at the recommendations, these are going to be the same as recommended for anybody that's 60 or 65, and maybe a little bit more Rodriguez-ism added to it. All right. So first of all, get a CBC on a regular basis from your patients. Well, we do that. Yeah, you do that. We do that for checking anemia. Also check the white blood cell count, which is very important. That may be the first indication you get of some sort of myelodysplastic change going on, all right? Whether it could be lymphoma, leukemia, it's important. It all bears something. Adenopathy check. Check your patient's glands. That may also be the first thing that you notice. For lymphoma, which is one of the main causes of malignant deaths that's not AIDS related in people that are HIV positive. This is why telemedicine doesn't do everything, all right? You can't check the lymph nodes through the screen. Spleen check. I know this is old fashioned. We still have to touch our patients and do checkups, all right? Ask them whether they have a history of fever of unknown origin. Why? Most lymphomas, they present with something called Pell-Epstein fevers, which is these unexplained fevers. And I see Ann Stapleton like, yes, this is infectious disease. But all these things that we sort of have forgotten that we learned years ago are now more vitally important because we've succeeded in having our patients live longer, just like everybody else. Okay? And this is where it's a little bit off the recommendations. If someone is a smoker, obviously you should be doing a low-dose CAT scan on a yearly basis. But I suggest that if you can't get that, maybe you should get a chest X-ray at least once a year. Right? What's the indication? I don't know. Maybe they have a cough. Wink, wink. Okay. All right. Near and dear to my heart. Everybody that's HIV positive should be checked for hepatitis A, B, and C. All right. Hepatitis B and C can be chronic diseases. You can get them. For example, hepatitis B, 80% of the people clear it themselves. 20% do not. What happens? If they're not treated, it can turn into cirrhosis. It could turn into different causes of death. Same thing with hepatitis C. And a large percentage of these patients never were jaundiced. You know, they may have had an illness decades ago that was just like a flu, and that's all they thought they had. So therefore, you always have to check for hepatitis B surface antibody. This gets confusing for a lot of people. If people have hepatitis B surface antibody, they've already either been vaccinated or they've been exposed to hepatitis B and they don't need anything. But if they don't have the surface antibody, they need to be vaccinated. Even if they have the core antibody, they need the surface antibody. Hepatitis A, if they don't have antibodies to hepatitis A, they need to be vaccinated. All right? Hepatitis A is carried through waterborne illnesses, but also through sexual contact. All right? It's all in the stool. If the person has hepatitis B, this is surface antigen. The antigen is the actual virus. You need to treat, and the majority of heart medications, all right, contain tenofovir, which is one of the treatments. So you're doing both things. You're treating the hepatitis B, or at least controlling it, and you're also treating the HIV. Something to remember here. If the only treatment you're giving them is the heart medication, in other words, the HIV medication for the hepatitis B, you really need to be on top of the patient's adherence. Because if they go on drug holidays and they have active hepatitis B, you're basically just holding the gorilla behind the door, right? They stop taking it, the hepatitis B is going to come back with a vengeance. So they need to know that. Hepatitis C, you have to check for their antibodies. There's no reason anybody nowadays should not get treated for hepatitis B. The treatment is expensive. Almost all drug insurances and Medicare will pay for it. One pill once a day for 3 months or 2 months, 90-something% cure of hepatitis C. Okay, so once treated for hepatitis C, for example, and this, obviously this is like what I love. You need to follow people up if they have cirrhosis every 6 months with an alpha-fetoprotein and an ultrasound at least, because they're at high risk for hepatocellular carcinoma. So just because they have been treated successfully from hepatitis C and you don't see any virus in their blood, they can still get hepatocellular carcinoma. So, treat blood pressure. Here, how did I know we were going to talk about this? Treat hyperlipidemia. This is a big deal, a big deal. Place the patient on a statin, all right? Be your charmingest and convince those patients that don't want to take it why they need to take it. That, my friends, is the art of medicine, not the science of it. All right, obviously treat diabetes. This seems like simple stuff, you know, and it really is, but sometimes we just get ourselves lost in the weeds of just the HIV, all right? And well-treated patients with HIV are not really dying from HIV per se. I have a very high index of suspicion for anything that's cardiac related. Another story, a friend of mine, he and his wife were just having dinner and he's like, you know what, you're a GI doctor. I get heartburn every time I get on the treadmill. You know, it just tightens up. And he did this. You know what that means, right? 2 weeks later, 5-vessel bypass. So have a high index of suspicion when the patient tells you, you know, I get short of breath when I'm hiking now. You know, I get this little pressure, but it's nothing. When a patient tells you their diagnosis, don't believe them. Make up your own. That's why dyspnea on exertion, which is shortness of breath, that may be the only sign that people have of heart disease, of a heart attack. Everything is not the classic chest pain going down the left arm. So, colonoscopies, again, near and dear to my heart. The recommendation now is that everybody should get a colonoscopy at age 45, unless there is a very pertinent family history of colon cancer. Then when should they get it? 10 years before the age of that person that had colon cancer. So let's say that Auntie had colon cancer, was diagnosed at age 50. You should get a colonoscopy at age 40, not 45. Very important. Mammograms, get them yearly to every 2 years. Cervical pap smears every year. Anal pap smears. This is all over the place, all right? Because if you're a gay man that is high prevalence to being exposed to HPV, all right, you still have a very high risk of anal cancer. But today we're talking about just people that are HIV positive, even though they're on heart medication. They should get a yearly swab. Depending on what's seen, they may need to get a high resolution anoscopy from that. PSAs. I don't know about anybody else. I'm seeing more prostate cancers in men over the last year than I've seen in a long time. So I don't know if that's because the US stopped recommending PSAs for 7 years and now people went undetected and suddenly we're seeing it. But get PSAs, I would recommend at least on a yearly basis. And again, maybe your patient is having problems urinating and they just a little mention, that's enough to get a PSA. Vaccinations, vaccinations, vaccinations. All right, so I have a theory. Over the last 2 years in the United States, the average life expectancy has decreased. Why is that? Is it because of obesity? Maybe. Is it because less people want to get vaccinated for certain things? There's a theory that that's part of it too. So just remember that the life expectancy from the 50s and the 40s before there were vaccinations was vastly lower than where we are now. All right, science has proven that vaccinations save lives and increase the quality of life. And that includes pneumonia, shingles, meningitis, COVID vaccines, flu vaccines, RSV, Hep A, Hep B, monkeypox. I know there are a lot of vaccines. Isn't that great? There are a lot of vaccines. All right. So this is one that I guess I'm focusing on this one because I think that I am a little too relaxed about this myself. So if I beat the drum on this, then maybe we'll all learn something. Start to assess your patient's social risks, all right, that are psychosocial, meaning depression, suicide, violent domestic situations, drug abuse, and alcohol abuse. Those all lead to deathly situations and outcomes. And again, too often in our community, I believe that we accept this behavior as normal for our community. All right, so sorry, folks, just because you're going to Arenas every Friday, and 5 martinis later, it's okay because everybody's this, and you do that all the time, it's a lot. So that needs to be kept in context. It's just the reality of it. If we're going to be doctors and we're going to be healthcare workers, then we should be that. So, bottom line, and I know that a lot of this appears second nature, and it should be, is that we need to view our patients as more than just people or a person with HIV. All right, they are people of a certain age that have the same propensity to certain illnesses and maybe more than someone of the equivalent age and social circumstances. So thank you. That in a nutshell is what I wanted to talk about.